name is Sarah Maines. Hello, my name is Sarah Maines. Thank you for joining us today. I am the Liver Cancers Program Director at Global Liver Institute, the world's largest liver patient organization. We bring together more than 200 organizations across our council, campaigns, and events to advance liver health as public health, to both prevent liver disease and scale optimal approaches to improving the lives of individuals and families who are impacted by liver disease and liver cancers. GLI's October is for Livers campaign is the first and only global campaign that's dedicated to public awareness, policy, and clinical practice needs to prevent and manage liver cancer while educating and empowering those living with and impacted by liver cancer. We are so happy to have you as part of our campaign. The 2023 October is for Liver campaign will not only push boundaries in equity, advocacy, and innovation by connecting diverse communities around the world to collectively tackle liver cancer, but the whole is greater than the sum of its parts, and this could not be more accurate to describe GLI's value of driving a better future in liver health through our global and health equity approach. Today's conversation will feature Dr. Patricia Jones, hepatology specialist in the Division of Hepatology at University of Miami, and Dr. Yvonne Flores, associate professor in the Department of Health Policy and Management at University of California, Los Angeles, Fielding School of Public Health, and a research scientist at UCLA Center for Cancer Prevention and Control Research. Welcome. Joined by your research initiative, you are going to be sharing your collaborations and how they came to be and what you hope to achieve together. We're so thankful that you're here. Welcome.
Thank you.
Thank you, Sarah. Thank you for having
To
us.
start off, I'm hoping, before we dive into the specifics of your research, could you provide background on the area of your expertise within the realm of liver health? Dr. Flores, your focus on research, and Dr. Jones serving as a healthcare provider and researcher. How did your collaboration come to be?
Well, yes, thank you. So I'm trained as an epidemiologist and as a health services researcher. The main focus of my liver disease-related research is on the prevention of liver disease, especially non-alcoholic fatty liver disease, which is an earlier stage of liver disease that can develop into liver cancer. Both non-alcoholic fatty liver disease and liver cancer disproportionately affect Latinos in the US. And an interesting aspect of my work is that I conduct research both in Mexico and in the United States. As a Mexican American, I'm interested in public health issues that affect Mexicans in both countries. Cirrhosis and other forms of chronic liver disease are consistently a leading cause of general mortality in Mexico. So in Mexico, it's the number 6th cause of death. And among Latinos in the US, it's the number 8th cause of deaths. And my research in this area started 20 years ago when I started my postdoctoral fellowship here at UCLA. And I conducted a study that focused on differences in risk factors for liver disease among Blacks, Mexican Americans, and non-Hispanic whites. And I think it's particularly important to conduct liver disease-related research because liver cancer incidence and mortality have been increasing in the United States steadily, even though there's been a decrease in overall cancer incidence and mortality over the last 15 years. That's not the case with liver cancer.
Thank you.
So I can introduce myself. I'm a hepatologist, and my clinical focus is patients who have liver cancer and also people with chronic liver disease. I've completed training in internal medicine and pediatrics, which a lot of people don't know, then gastroenterology and hepatology fellowship, as well as my Master of Science in Clinical Research. All that was done at University of North Carolina. And now I've been at the University of Miami for over 8 years, focusing on expanding our liver cancer program. And my overarching focus is on disparities in liver cancer, and there's disparities in risk developing cancer, liver cancer treatment, liver cancer outcomes, and compared to non-Hispanic white individuals from all races and other races and ethnicities have increased risk of developing liver cancer. And so what I use to sort of inform the work that I do is my own local experience. And essentially, we noticed here that our Black patients are least likely to be diagnosed at an early stage, least likely to receive treatment, and more likely to die earlier. And we have some really interesting findings in terms of, the fact that not all Black people are monolithic, right? And so there's differences within groups that are really important and inform that. So I'm going to pass it back to Dr. Flores. Maybe she wants to talk a little bit about how our collaboration came to be.
Sure. And I think you might want to, yes, it's not that slide. Exactly. So thank you so much. This slide sort of shows that what it is that we, how we came to collaborate. So Dr. Jones and I share a mutual interest and understanding and wanting to learn more about how it is that we can eliminate the increasing burden of liver cancer in Latino communities. And we had planned to collaborate since we first met at the American Association for Cancer-Related Research Science of Cancer Health Disparities Conference in 2016. So we met at that conference when we were discussing our different research projects at that meeting. And we, remained conference buddies and friends since then. And we had always sort of wanted to find a project to work on. And finally, this year, we were able to submit a grant, a U01 application in June to conduct a study that will examine some of the genetic and environmental risk factors that are associated with non-alcoholic fatty liver disease related liver cancer, human hepatocellular carcinoma, which is the most common form of liver cancer, in a diverse group of Latinos. And our study is known as the GENIAL study because of its acronym. We're very excited that our study was selected for funding as part of the National Cancer Institute Liver Cancer Collaborative Projects that will be part of the Liver Cirrhosis Network that Dr. Jones is a part of at the University of Miami.
That's incredible. Congratulations. It's such an important thing to be, studied. And as we continue to make sure that liver health is a global health awareness and need, I'm so glad that you two are leading the way on these efforts.
Yes.
We're really excited about this as well.
Yes, absolutely. And there's actually other projects that Patricia and I are collaborating on. If you'd like to pass it on to the next slide, that's great. And I know this is a busy slide with some of the results of some studies that we're in the process of writing up for publication. So in addition to the GENIAL study, Dr. Jones and I are collaborating on 3 forthcoming manuscripts. For one project, we used data from the WHO, the World Health Organization, mortality information that spans over 60 years for Mexico and almost 70 years for the United States, where we're comparing age standardized mortality rates due to chronic liver disease during this time. And then we're using demographic forecasting methods to predict chronic liver disease mortality trends in both countries. And so the graph on the left show these results. And we found that although mortality due to chronic liver disease is currently higher for both men in Mexico, for both men and women in Mexico, our results indicate that over the next 30 years, females in the US are actually going to be having the highest mortality rate due to chronic liver disease. So we'll see if this actually happens, but it's based on current trends that we are seeing. Our second manuscript, we're looking at data from the National Health and Nutrition Examination Survey, which is known as NHANES, for the years 1999 to 2018. NHANES is a nationally representative cross-sectional examination survey. So it represents the United States population, and it's conducted approximately on 5,000 people every year. And our participants included adults 20 years and over. And our sample size for this particular study was almost 57,000 people. And we looked at trends over time having to do with the following risk factors for chronic liver disease: elevated liver function tests, or ALT or AST for men and women, hepatitis B or C infection, whether participants were heavy or binge drinkers, the prevalence of obesity, and the combination of obesity and heavy or binge drinking by race and ethnicity. And so these results, which are small, but they show how it is that Latinos have the highest rates of binge or heavy drinking of all race and ethnicities over time. And our third manuscript reports the findings of a pilot study we conducted with 100 cases of non-alcoholic fatty liver disease and 100 controls in Mexico to examine the association between metabolic dysregulation and non-alcoholic fatty liver disease. And what we found in this study was that when combined with other variables such as age, sex, body mass index, and the PNPLA3 genotype, which is a genetic variant that has been associated with an increased risk of fatty liver disease, 10 metabolites were identified using random forest analysis that predicted being a case versus being a control with an accuracy of 88%. So these results suggest that maybe a panel of metabolites could be used to help diagnose NAFLD, but obviously this is a pilot study with just 100 cases in control, so we need more studies to validate these findings and examine them in a larger sample of individuals with disease and without disease. So these are just some of the projects that we're working on right now, and that should be published in the near future.
Wonderful, thank you. And I know that you both had referred to some of these statistics and comparisons, but according to the National Cancer Institute, compared to whites, communities of color disproportionately suffer from higher rates of liver cancer, which obviously stems from a multitude of risk factors, including liver disease. So Dr. Flores, your research centering primarily on the Latinx community, and Dr. Jones serving the community that is predominantly Caribbean and Hispanic, what do you see what have you witnessed that make these populations more susceptible to chronic liver disease? And how do you hope that this collaboration will address these determinants of health to help us increase health equity?
So I'm actually going to take this one, Sarah, because I'm going to talk more generally, especially since we wanted to make sure that we were speaking to your entire audience. So they set the stage for understanding what the risk factors for liver cancer, or affectionately known as hepatocellular carcinoma, the one that we're going to focus on. And so we're just going to go through, in general, over 90% of people who develop a liver cancer, HCC specifically, have a chronic liver disease. They may be unaware of it. One of the things that when people think about liver disease and liver cancer, they automatically jump to alcohol. And certainly that can contribute to liver disease and liver cancer, but it is not the only cause. And so we've been talking about fatty liver disease, and the old name for it was non-alcoholic fatty liver disease. And recently nomenclature has been proposed that's metabolic associated steatotic liver disease. And that is a rising cause of liver cancer. And we'll talk a little bit more about that. But this is why this was actually the focus of the grant that we proposed, because that is a leading cause of transplant related to HCC in the US, and it's disproportionately affects certain communities. Also, viral hepatitis B and C disproportionately affects certain communities. They're more common in Black and Asian communities, for example, if we're talking about hepatitis B and also hepatitis C. And I'll show you that on the next slide. And then the other, which are much less common, but still can contribute to liver disease, which leads to cirrhosis, which can lead to hepatocellular carcinoma. And I have those listed on the slide. So one of the things that, I mentioned earlier, and I think it's really important when we think about communities, is that we have this artificial concept of race and even ethnicity, right? Which, race is basically stereotypic. It's a social construct, and it's how someone appears. But within a race, there are multiple different cultures, ethnicities. And that can influence behaviors, which I think is really important, which can lead to different causes of liver disease. So this is some work that was recently published led by one of my colleagues here, which actually looked at data in the state of Florida to try to understand whether or not we could tease apart which groups are more disproportionately affected by which conditions, right? We have the more common ones, Hep C, hepatitis B, fatty liver, and alcohol-related liver disease. But the reality is when you break it down, and you can see it in the bottom with the colors, that depending on the subgroup, there are certain risk factors that are more predominant. And why is that important? That's important because the goal is to prevent liver cancer. So in order to prevent liver cancer, you need to understand which groups are disproportionately affected by what and target your prevention techniques, your messaging in a way that's culturally relevant. And so here's an example of, and you can see a little, right? For example, if we break apart Asian groups, fatty liver is much more common as a cause of HCC in Filipinos compared to hepatitis B in Chinese. The groups that we're interested in, if we look at men, for example, as Yvonne, Dr. Flores mentioned, alcohol-related liver disease is very common in both foreign-born and U.S.-born Mexican, but Puerto Rican men more commonly affected by hepatitis C. So these are why certain communities are affected, and there's a lot to it. A lot of it has to do with diet. A lot of it we know, a lot of it we don't know. A lot of it has to do with exposure in certain times, right? Before we had sterilization, et cetera. So lots of things that differentially affect communities.
Thank you. Can you elaborate more on the gaps that exist within the liver cancer landscape that prompted you to further look into this? I know that you've talked about, obviously, the health equity data gaps, and what do you hope to accomplish with these findings?
Well, before we get into the gaps, I wanted to just round out this question with some specific risk factors that affect Latinos in the U.S. For chronic liver disease and also for liver cancer. And so, as Dr. Jones just mentioned, although Latinos can have any of the risk factors that she just covered, there are specific factors that are more common among Latinos in the United States. And so even though my research is mostly focused on the determinants that increase susceptibility to chronic liver disease among Mexicans in the US and in Mexico, these factors apply to most Latino groups, just in different proportions. But among Mexicans, so, for example, the bar graph that's on the left shows that obesity is a major factor that affects is a risk factor for Latinos, which can lead to fatty liver. And so the results of this study are from NHANES, the study that I just mentioned a few slides ago. The participants who were in this study from 2017 to 2020. And as you can see, Latino men and women in the United States have the highest prevalence of fatty liver due to obesity. Another major risk factor for Latinos in the US that Dr. Jones mentioned is alcohol. So this is this graph on the right presents the results of our research that shows that Latinos in the United States have the highest prevalence of drinking over time from 1999 to 2018. And even though there's a downward trend for men on the left, you still see that Latino men in purple have the highest rates, as well as Latino women in purple have the highest rates on the right. And another less studied but important contributing factor among Latinos is a potential genetic predisposition that may contribute to the increased susceptibility of chronic liver disease among Latinos. So the PNPLA3 variant, there's a specific PNPLA3 variant that has been demonstrated to have the most robust and consistent genetic association with fatty liver of any single nucleotide of any variant, and that the frequency of this genetic variant is higher among Latinos. It's 49%, Then among non-Hispanic whites, it's 23%, and among Blacks, it's 17%. So this graph in the blue, orange, and gray show how it is that Latinos have a higher prevalence of this genetic variant, which is also possibly contributing to their increased risk and is one of the factors that we will be investigating in the study that we recently got funded.
So I want to go back a little bit to your question about equity and disparities, because I think that it's really important. And again, you never know who is watching the video and how much familiarity they have with the term. In my experience is that actually most people don't know the difference between disparities and equities. So I always like to show this when we're actually talking about that. And I applaud GLI's commitment to achieving health equity, but I think it's really important that the audience understands what it is. So I have the definition there and the relationship, and I'm just going to read it quickly. While I'm reading it, maybe look at the graphic and see if you can understand why, we're seeing what we're seeing. But health equity is actually the ethical and human rights principle that motivates us to eliminate health disparities, which are key differences in health or its key determinants, such as education, safe housing, freedom from discrimination, that adversely affect marginalized or excluded groups. So one of the things that when we're thinking about health equity, think about it, how do we apply it in the context of research or just in general, even clinical, when you're thinking about like, how do you approach disparities? And what you can't do is just to look at, an individual and say, well, this person is the reason, right? Like it's that these people drink more, right? So that's an example we've talked about already, is that certain groups maybe have higher harmful drinking patterns. And maybe that's why. But is that all it is? Well, why? Why do they drink more than other groups? Is alcohol priced differently in certain communities? Or advertisements targeted? Sorry about that reminder. Are advertisements targeted differently to different groups? And so it's really important that we're not thinking just about the individual, and not that we're laying blame, but sometimes that's how it comes across on an individual. But we really think about, how does the individual fit into the institution, their local environment, family behaviors, family support, community, what sort of safety net services are available, how accessible is healthcare? Is that part of the reason that people are presenting at later stage, especially people in specific groups? And then we really have to think, on a societal level. That's why that's the biggest thing, because actually some of these are the components that actually impact health outcomes and access to care. So I think now we kind of understand the relationship between equity and disparity, it's a little easier to sort of talk about the gaps.
Mm-hmm. Sure. So one of the gaps that we want, there's many gaps, but one of the gaps that we think is interesting or important to investigate is the fact that liver cancer is a lot more common in patients who already have some form of chronic liver disease, and it's thought that this is due to inflammation in the liver and regeneration. However, not everyone who has liver disease goes on to develop liver cancer, and we are interested in finding out or investigating why it is that certain genetic factors, severity of liver disease, and exposures to certain environmental factors can increase risk of liver cancer in Latinos. So even though Latinos have significantly higher risk of liver cancers, many studies don't include Latinos in large enough numbers to be able to investigate why it is that they are that they're more susceptible to liver cancer and fatty liver. Other studies may focus on one specific group, such as Mexican Americans, which is what I've done. So one of the studies, papers that I've published is listed on the left, which focused on what specific genetic variants are associated with an increased risk of elevated liver function tests. And so my research so far has focused on very specifically on Mexicans. So that's a gap. We need more research that's focused on all Latinos, which is what we're hoping to do with the study that we are going to be collaborating on. And another gap is that Latinos are underrepresented in clinical research trials. And finally, as Dr. Jones mentioned during her great explanation of like the difference between disparities and and equity. Another research gap is the lack of research about specific social determinants of health that contribute to liver disease disparities. A few years ago, my colleagues and I here at UCLA conducted a study, which the results are shown on the right, that identified disparities in liver cancer, hepatocellular carcinoma incidence, stage, and survival using SEER-18 data, which is a cancer registry from 2000 to 2015, and we included almost 46,000 cases of HCC and found, with few exceptions, that HCC incidence, distance, stage at diagnosis, and poor survival were highest among the low SES groups for all race and ethnicity. So not only are there differences by race and ethnicity, and certain racial ethnic groups are at higher risk of developing HCC or hepatocellular carcinoma, but this also varies by socioeconomic status. And we think that this is also an area of research that needs a gap in liver cancer research.
No, thank you. I mean, I think that that's something that GLI certainly prides ourselves on, is being able to lift your voice and show what you're doing. And we truly commend your level of expertise and bringing these gaps forward, because it's so important. So thank you for that. How do you see it as, we hope to help translate the research findings into patient care improvements as our part of really driving patient advocacy and education at GLI and for our entire liver community? How do you see your research initiatives really reshaping clinical practices and patient care?
So this is, I think, super exciting. I think one of the, more exciting aspects of doing research is how creative you can be in terms of thinking about the future and, how we can all participate. And so certainly the advocacy component is so important, and the voice of patients and families is so important, so that we can make sure that the future, when we're reshaping with the desires of those who are most affected in mind. And so one of the things that I think we're most hopeful for is that some of this information we don't have in certain communities. So just by having this information, this data, genetic data in certain communities, that will increase what we understand. And what's really important when you're doing research is this thing called generalizability. So if I find this in group A, does it matter for group B? Well, we can't know if no one from group B was included, right? Mm-hmm. And so making sure that whatever clinical algorithm we devise is reflective of the groups that are actually most affected. And so by just one, that's innovative in and of itself. But two is the idea that there's so much that's changed. I'm an ex-centennial, so there was a time where we didn't have computers and we had, rotary phones. And so now you can see all of the differences in technology, and it's very similar in medicine, right? In the past, getting access to genetic information was very, very difficult. Now it's not. Now anybody who wants to, I even got it done on my dog, in case you're wondering, but anybody can have access to genetic information, and that information is very powerful. So what we're hoping is that this will be incorporated into clinical practice algorithms that will help us to identify people who are at highest risk to develop liver cancer at earlier stages, because that's the goal. The outcomes are better when people are diagnosed at earlier stages. And then the next level would be even prevention, right? So finding those people who are at increased risk, and then targeting those people for specific studies, potentially, or specific treatments. And this is known really commonly as like individualized medicine or precision medicine. But our health systems, both UCLA and University of Miami, along with others throughout the US and throughout the world, have made a commitment to precision medicine. And so building the infrastructure so that we can have this information on all patients. So right now it seems like something so far-fetched, which is why I have some of the futures. I don't know, maybe we'll be doing this virtual reality thing in the future, right? That'll be part of our training. Who knows? But I think that this is really important to think about all the groups that are impacted, and how, as we think to how this information will be increasingly more available, that we really adapt what we do now so that we're targeting the most vulnerable communities.
Dr. Flores, anything to add? I love that. And thank you, Dr. Jones.
Yes, no, that was great. I think I'm supposed to end with what are some of the future changes we'd like to see. So if we could just get the next slide.
And I will say, Dr. Flores, you two complement each other so well in that way. I always look, from one being West Coast, one being East Coast, you have academic and bedside, how you look at that collaboration from different and similar shared backgrounds really reveals to us that power of a multidisciplinary team and the benefits that is to the clinical community and also the patients. So thank you so much. And of course, there's a lot more to be done to make a difference for liver disease and liver health. But as you had said, how to move the needle forward and what changes do you hope to see in the future?
Absolutely. And so we listed on this slide what it is that we're sort of hoping for changes in the future, right? But before I go into some of them, I just wanted to sort of thank you for bringing us together, but also like shout out to academic conferences, because it is quite possible that Patricia and I, being on opposite ends of the country, might not have ever met if it weren't for the liver meeting, which we met at every single year, and also this health disparities conference, or cancer health, specifically cancer health disparities conference, where we were generally the only two who were presenting on liver disease.
It's increased though. There were about 6 or 7. I just came back.
Yes.
But now.
But I mean, however many years ago we met, like 7 years ago, it was mostly us and just maybe a couple other posters. So yeah, so yay for academic.
Truly, yes. It's the power of networking, right? And coming together in a shared space, but also being able to use your voice and connect with new people.
Absolutely. So one of the things that is listed on here as changes that we'd like to see in the future is understanding why certain communities are more affected by chronic liver disease and liver cancer. And we hope that the genial study that we'll start on later this year will help to generate some of the changes that we'd like to identify in terms of understanding why it is that all Latinos are more affected by liver disease and liver cancer. There's also more work that needs to be done to identify and address the social determinants of health that lead to disparities in liver cancer incidence, stage of diagnosis, and survival in different groups, not just Latinos. We also need more research and hopefully clinical practice that incorporates genetic data into prediction models that could be used for patient care. We would also like to see more culturally tailored interventions that can reduce liver cancer risk by hopefully preventing chronic liver disease in the first place in many of these groups. And finally, strengthen collaborations between healthcare institutions and communities, which is one of the things that Dr. Jones and I are doing by collaborating on this study that we're very, very excited about. So that's pretty much what we're hoping to see in the future. And we hope that all of these things will happen in the near future, not in the long-term future.
Absolutely. Dr. Jones, final word?
No, not really. I'm just really excited about the opportunity to work with you all. And I appreciate your support and certainly highlighting the work that we're doing, because I think it's really important. And I think that patients and families want to know about the work that we're doing and how they can help, certainly. But I'm excited that, the voices are being heard. And this is really quite important. And I'll applaud the National Institutes of Health, too, for recognizing that this group really needs a lot of attention given increased risk. And so I'm just very excited about the work, excited to continue my partnership with Dr. Flores, my partnership with GLI.
Mm-hmm.
Well, thank you. I couldn't have said that better. I'm thankful for both of you in terms of being colleagues and also friends. You have worked together with GLI and myself for more than a year now, really looking at in last year's campaign, starting to guide and move forward health equity in the liver cancers landscape, bringing forward disparity and health equity conversation in our roundtable series. And so to be able to look ahead at even in the short year, how far we've come and how important these relationships and collaborations are to us, I thank you for that. This has been a tremendous conversation, and your commitment to the liver community and the patients that you serve and we all serve, thank you. We couldn't do this without you.
Yes, and we also appreciate so much that you're giving us this platform to be able to communicate and share our academic work with a general audience.
Absolutely. You have our full support always.
Thank you.
Thank you. Happy October.
All right.